Hello, and welcome to the ImpediMed webinar series. My name is Joanne Yao, and I am the Senior Director of Marketing for ImpediMed. Today's webinar is titled Reimbursement, Best Practices for Building a Successful Lymphedema Prevention Program. We have two very experienced panelists joining us today, Dr. Manpreet Kohli, Breast Surgeon, Director of Breast Surgery, Monmouth Medical Center, and Chelsey Jaworski, Senior Director of Onboarding and Reimbursement with ImpediMed. We will start today's webinar with a live presentation from Chelsey, followed by a panel discussion. We encourage you to participate by submitting questions via the Q&A icon on your screen at any time during the webinar. We will answer as many questions as possible during the next hour, and we'll follow up on any questions that we are not able to address live. We're happy to offer certificates of completion for your participation in this webinar upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your ImpediMed representative. All webinars are available for replay approximately 1 week following the event. You may find them on ImpediMed's Oncology YouTube channel. Please subscribe when you're there. Now I will turn it over to Chelsey.
Thank you, Joanne. So today's presentation objectives, we're going to understand the CPT code 93702 and how you're going to increase your patient access to the L-Dex technology. Next slide, please. For CPT code 93702, I'm sure most of you are familiar with this already. The RVU is 3.90. The Medicare national average payment is approximately $143.25. The APC is 5721, and approximate payment is $139.55. Next. So what are the applicable diagnosis codes typically used in conjunction with the CPT 93702? Get this question all of the time. The diagnosis codes help the payers evaluate the medical necessity of a procedure. But while there are no specific diagnosis codes for the L-Dex, providers may use a diagnosis code of an underlying disease. Examples, several different breast cancer codes, starting with the C50 series, melanoma with the C43 series, and lymphedema, I89.9. There are some payers that have specific policies that require you to use a particular diagnosis for the L-Dex, and our reimbursement department can help you with that. Advance, please. So can a therapist bill CPT 93702? Another question I get all the time. So the provider should contact their payers directly to confirm the CPT code 93702 is an approved CPT code under the therapy contract. If you need assistance, I can offer my assistance to you. I am currently working with a couple of therapists to get them contracted with Medicare. Therapists practicing in independent rehabilitation facility should contact the payers to pursue adding the 93702 as an allowable service, as 93702 is not a physical therapy code. However, physical therapists, when you are an on-site facility, can bill under the facility's tax ID number. The therapist practicing in hospital-owned rehabilitation facilities should look into pursuing the facility fee for the CPT 93702 as long as the L-Dex test is ordered by a qualified medical professional. Next. So the L-Dex reimbursement coverage. Advance. So while there has been improvement with CMS, the Medicare, commercial payers may still deny coverage for customers. However, we have an in-house case assistance program that has made tremendous strides in challenging these non-payer coverage decisions. And that is achieved by working very closely with the clinicians and patients who are willing to appeal for coverage. Our program is available to help the facilities, clinicians, patients secure coverage on a case-by-case basis. Critical elements for the program include working with the physicians, practices to convey medical necessity and to leverage the clinical and economic publications as well as the evidence. Next. So what payers are covering L-Dex? You see here on this map is our Medicare administrative contract jurisdiction. All Medicare jurisdictions are currently covering the 93702. There is reimbursement for various private insurances on a case-by-case basis, and I'll get to that a little bit further in the presentation. And the Medicare national average payment is about $139. We'll like to say that the periodicity of the assessment we are including in our template letters for the case assistance program. So the periodicity is every 3 months for the first 3 years and every 6 months after that, and then yearly. Advance. This slide is a Medicare Advantage, shows that there's a substantial portion of Medicare enrollment. So the graph on the left shows the Medicare Advantage enrollment. So these are all the payers that provide the Medicare enrollment for their commercial series. So United Healthcare, you see, is about 26% of all Medicare enrollees opt into the United Healthcare program. Then Humana, the various Blue Cross Blue Shield plans, and then other various insurances. The graph on the right is a critical piece, especially with the evidence that we have developed in the case assistance program. You can find your own particular state in here. I will use Florida. 48% of all Medicare enrollees have opted into Medicare Advantage. And you'll see in the next coming slides why this is a critical piece of information. Next slide. So I want to say probably the last 8 to 10 weeks now, we have tracked the trends throughout the case assistance program. And we have received 100% approvals for Medicare Advantage cases. So yes, that means that you have to do a pre-service review for Medicare Advantage. I know there are still some sites that are just submitting the claim and not doing any pre-service reviews. You're probably getting denied on the back end for Medicare Advantage. If you do a pre-service review for Medicare Advantage, it is very probable that you will have them covered. So this has just been an increased revenue for facilities nationwide. Originally, you just had the Medicare coverage, Medicare and Medicaid, but now you can add Medicare Advantage on top of that as long as you do the pre-service review. The average payment for Medicare Advantage is about $190, which is significant compared to the Medicare, the straight Medicare national average. What you see on the right is an example template letter. We have created them for each specific MAC. So you see this one is for NGS Medicare, the northeastern part of the country, but we have developed these for each specific MAC again. These can be provided to you if you don't utilize our case assistance program just by reaching out to us. And we'll give you the contact information following this webinar. Again, 100% approvals. So this is your commercial coverage landscape. I always like to be completely transparent with the sites. There are about 63 commercial payers that deem this 93702 as experimental investigational. That does not mean that they will not overturn these cases upon pre-service appeal or even post-service appeal. I do like to say that, it says pre-auth required. There are specific insurances that will say no pre-auth is required, but you can still initiate a predetermination, and that's what we recommend and follow in the case assistance program. Next slide. So best practices, working with multiple sites nationwide over the last few months, standardized best practices. So I normally follow this particular slide as an agenda slide when speaking to new offices. So the testing protocol is critical in knowing how your particular site is seeing the patients. If you're seeing them every 3 months, every 6 months, some are doing that just due to the lack of reimbursement. So why this is critical for us to know here is because we will initiate a year's worth of assessments according to your own protocol for your site. The next one is the EHR documentation. A few months ago, I was reviewing these cases that were getting submitted through the case assistance program, and you'll see a little example of the documentation further on in the presentation. But I was noticing that nobody was documenting anything except for the L-Dex score. No reason why this particular patient needed the assessment, just the score itself. So to show and demonstrate medical necessity for a patient and medical necessity to support the code being submitted for payment, we developed a smart phrase or documentation template for whichever EHR that you use to be uploaded and incorporated into your office note in order to submit to the insurance companies. The second part is doing a view-only access. This is for the case assistance program. View-only access for our team to go in and extract the clinical information necessary to submit to the insurance companies. I have had multiple conversations over the course of the last couple of months. I know that your team, there's a huge turnover rate. Your front desk team, your medical assistants, don't have the bandwidth to submit us cases for assistance or even do it and submit it to the insurance companies on their own. So that is what we are here for. We are an extension of your office, your practice, your facility. We are here to help you get that additional revenue for your site. So view-only access is a critical piece in order to extract that information. So your team just sees the patients and does the assessments, and we can take care of submitting the predeterminations for you. Another critical piece is figuring out the billing portion initially with the site. So do you have that 93702 already added to your charge master? If you don't, this is the most critical piece. Whether you are going to set that charge at a cost that if you are planning on balance billing the patient, you set it low enough that yes, you are still able to recoup the Medicare cost or the Medicare payment, but if you must balance bill the patient, you keep that cost down to about $50 to $75, more palatable charge for the patient, similar to a copay. That way, that patient will stay engaged. They will still be more up to coming in for their quarterly visits or their visits twice a year. If you set that charge or the balance bill onto the patients more than $75, your utilization will drop. And I have that. I'm working with a bunch of sites right now trying to get them to either adjust off that non-coverage or make it a more palatable cost, $50 to $75. Again, we are here to help you. We do pre-service reviews as well as the post-claim assistance as well. The workflow, another critical piece. So predeterminations can take anywhere from 3 to 10 days. I will tell all the sites that we can initiate those predeterminations even on the same date of service. As long as it's the same date of service and not the next day, we can still initiate a predetermination and follow that up for you. Again, it's how many times that patient is seen pre-surgically and the protocol. Next slide. So this is the example documentation, smart phrase, documentation template, however, dot phrase, whatever EHR that you use. This is what has really made a difference and increased the commercial payer approvals. So with this, you'll see the red font is really the only place where you need to change if that patient is coming in for a baseline 3 months, 6 month, a year follow-up, and then enter in the L-Dex score. We have already incorporated, and you can edit this as necessary, but everything is already incorporated in there according to our own publications and protocols. What I like to find out is with these sites, what's your goal for the program? Do you want to break even or do you want to generate revenue? So I have been, really focused on developing a 3-month pilot program with new sites. I want you to test all of your patients, utilize our case assistance program for predeterminations, and exhaust all levels of appeal. Do not charge the patient. That way you can test all the patients. They don't have to worry about another bill coming in. A mix of the denials and the payments is revenue positive. And I will say that the case assistance program, recently, I just had to do numbers last week, we have a 98% approvals for commercial payers if you go through and exhaust all levels of appeal. So it's worth it. So if you utilize our program and you're testing all your patients, you are going to generate revenue, especially with the Medicare Advantage recent developments. Next slide, please. So what happens if the policy is to charge your patients when the insurance denies coverage? So this is what I see a lot for particular sites that don't necessarily utilize our program, but the providers are conflicted. They are following their institutions guidelines, and honestly, it's cruel to insist on cash for denials, illegal for CMS without an ABN, but these providers want to prevent lymphedema. So after a long discussion that these practitioners have with the patients get upset. They decline having this assessment done. And then, they're now at risk for developing lymphedema because now they're not going to have the assessment done because they're going to be charged over $100 for having this assessment. A cash pay policy is self-defeating. So the program forgoes revenue and fails to serve the patient. This assessment is a 30-second assessment. It takes less time than a blood pressure check. So in spite of 70% of denials, and that's a predetermination denial, that is not going through the appeals process, your revenue is positive with this particular technology. So when the facilities stopped asking for cash for denials, the volume jumped. And that is with so many different sites that I worked with that have done that pilot program. We're able to show them with the accounts receivable report after 3 months or 6 months that they are not only breaking even, they are now generating revenue. So they can continue to adjust off the charge and not charge the patient. Next slide. This is an example diagram for you. So, when you work with our case assistance program, there is stuff to get in place, the EHR, the login information for Availity or Navinet. But once all of that is established and who's going to send the intake forms to us, or are they going to just send the name to us just because we have EHR access? This is just something that I will be able to provide to you after our discussions. And this will outline everything for everyone on your staff, your directors, your front desk, your medical assistants, the revenue cycle team, because everyone really needs to communicate. Everyone needs to come together. We're thinking about the patient getting this assessment, and we want this patient to have this done. So they are, no longer at risk of developing lymphedema. So I will be able to provide this for you. Some examples for you. I'll run through it. The surgeon provider, obviously, they're the ones that initiate the patient getting the SOZO. Whether they do a baseline first and then they submit the case to us, we'll walk through. If approved, at predetermination, then they bill the insurance right away. Obviously, Medicare is 100% covered. You can just submit those claims. All others, depending on your time to drop the charge, that's another part of our discussion. It's a very well thought out workflow that we develop, which is site specific between your front desk, your front office, your revenue cycle team, compliance, and legal. But the goal is to get everyone on the same page and moving forward and having the patient being able to have access to this technology. So I like to think that the case assistance program is the single most powerful tool to establish coverage. Again, we're an extension of your office or facility. We constantly provide team education, not only to our own internal team, but to your sites, to whomever, the revenue cycle team, the front desk, the physicians, compliance, legal, everyone. We offer pre-service assistance, which is critical. Again, with commercial payers, it is critical that you request a predetermination. We do also provide post-service assistance. So what makes our percentage so high of approvals? We do anticipate the payer objections. Not only do we have the case assistance program, I also work the top-down approach. I've worked with the medical policy committees of the commercial payers over the last decade with various technologies and gotten them covered in turn from experimental investigational to medically necessary. So I do have discussions with them, what they're looking for in order to provide coverage and change their medical policies. We have a very comprehensive appeal strategy. So whenever we have a case denial that comes in, we are always looking at that language. We're looking at what's in that denial letter, what that particular reviewer looked at, whether it be a particular publication or health technology assessment, develop a rebuttal to that, which is patient specific, and appeal that original denial. The critical mass of case-by-case coverage is also included in that particular slide. So anytime we have cases that we have an external appeal overturned, I can use those in my medical policy discussions. Again, how we appeal denials, it's an evolving strategy. I am constantly, and the team is constantly updating our template letters in order to provide the best possible outcomes. Again, reviewing the denials as well as the approvals from the external appeals that are getting overturned. So it is worth it going through that appeals process that we do on behalf of your site and the patient. When those external appeals get overturned, again, I can have that conversation with the medical policy committee and say, your utilization management team is overturning these. I have 5, 10 of these overturned now. So you really need to change your policy. Next slide, please. So again, ongoing discussions with the medical policy committees. We are going to be submitting as soon as the 3-year publication comes out for the PREVENT trial and setting up face-to-face meetings with them. And data tracking by our utilization management case-by-case coverage. Again, we are tracking every trend known to man. So every single case that comes in, yes, I am looking at those denials and approvals. And with our 98% approval right now through the case assistance program, that data tracking is proved beneficial. So what to send to ImpediMed? So the case assistance program, if your site does not provide EHR access, then this is the case assistance form right here on the right. I normally provide you a master intake form with your physician or facility name and information. For pre-service review, on the left, you need to complete the intake form, send the progress notes, either to physician or PT notes, an op report if available, pathology report, insurance card, obviously, and the SOZO report with the documentation. Post-service, the only additional thing would be the ICN claim number and the total amount charged. The total amount charged isn't what you charge for the SOZO. The total amount charged is for the total amount charged out for that patient that day. That is how the insurance companies identify that when we submit the post claims. And here's the fax and email address to submit your individual cases to us. Next slide. This is just a little example of when we go into the EHRs, or if you don't provide us with the EHR access. This is an example of what you should look for of the information that we would need to submit to the insurance company to show medical necessity. So you see here a plastic note, or the biopsy, or the OT that came back to OT return visit for the SOZO. You see on the right, one of the arrows is specific. Somebody had set up their particular appointment type as SOZO. Advance, please. So this is also an example of an accounts receivable monthly report. Initial discussions I have with sites that have been up and running for some time that perhaps we're not doing any pre-service reviews. I like to see I give them this example report. I'd like to see the ones that were paid, the insurances that paid, as well as the ones that were denied, right? This is the ICN number and the total amount charged. So that way I can take this information back to my team, provide it to them. If we do have the EHR access, it's absolutely fantastic, because I can just take this report, go into their system, and automatically not only work on the post-claim denial appeals, but turn right around and initiate predeterminations for every single one of the patients that their accounts receivable team provides on this report. And thank you for listening.
Thank you, Chelsey, for your excellent presentation. And we'd like to keep you on video, please. And also welcome Dr. Kohli also. So as we get sorted here, everyone, we heard a lot of great information from Chelsey, and we have some questions coming through already about access to the slides. So what I'd like to let people know is that we were going to make this recording available. Usually it's about 1 week after the event. If you want access to the slides or specific information for your practice, you can respond to your Zoom registration request. Let us know you want your own consultation. We will follow up with you. You can reach out to your ImpediMed representative. They will help get you the information, but we're more than happy to have conversations about your specific scenario. So we got 9 questions during your talk, Chelsey, and I think some of them we can get to before we start asking, engaging with Dr. Kohli and what's going on in her practice. So if you don't mind, if we could just kind of give some quick answers to a few of these, that would be great. The first question, Chelsey, is why for lymphedema we use diagnosis code I-89 instead of I-92 or I-97.2. And you're on mute, Chelsey.
It's really up to the provider to submit their own diagnosis code. We have a coding guide that provides example codes that you can use. So again, it's always up to the provider.
Thank you, Chelsey. When you're doing the appeal process for non-covered claims, what is the experience of the patient? What's the patient experience?
It depends. So the patient, we've had a lot of patients that have been really engaged with us, especially the Medicare Advantage. We are now working with them to go forth with an ALJ judge, which is a post-claim review. So we will be doing that arbitration with them. They're really excited to do that. Honestly, they don't want, and these are most oftentimes the ones that have that fee from their site, from their particular facility for the balance billing. So they don't want to have to go through and have to pay that cost. So they are very thankful that we're there to assist them and get this approved for them.
Wonderful. So we have a lot more questions coming in. I want to hear from Dr. Kohli. I think you're going to have an opinion on some of these as well, based on your experience. So Dr. Kohli, thank you for joining us. Would you mind just sharing with the team, they heard from Chelsey. Would you tell us a little bit about your current role and practice?
Of course. Thank you so much for having me. And yeah, there were a lot of things that Chelsey brought up that I felt like it was deja vu. So I'm Dr. Kohli. I'm the medical director of the breast surgery program at Monmouth Medical Center. We're part of Rutgers Robert Wood Johnson Barnabas Health System, and we're located in Long Branch, New Jersey. So I'm a breast surgical oncologist. 100% of my practice is breast surgery. I'm also the cancer liaison physician for the hospital through the Commission on Cancer and the American College of Surgeons. So that basically means that I'm reviewing the cancer-related statistics for our hospital, and with a special focus on improving the quality of care. So when I'm not operating, I participate in several of our accreditation site visits with agencies like the NAPPC and COC in my role as the breast program leader. So this is certainly something that's been very important to me.
Thank you, Dr. Kohli. And would you talk a little bit about the lymphedema prevention program that you currently offer your patients, and a little bit of background on where you started and how you got to where you are today?
Oh, maybe a little bit of a long story, but I think it's not only important to provide the best care for your patients, most state-of-the-art care, most up-to-date care, but building a lymphedema prevention program, it helps to prove to these accrediting agencies that you do strive to provide the highest level of care. So from a clinical standpoint, we as clinicians know that it can be very debilitating for a patient to develop lymphedema. It can really affect their quality of life, but also have a lot of healthcare related costs. So, when we're talking to patients about their treatment plan, we don't want to compromise our thoroughness of treatment, of course, but it's also important to be cognizant of the long-term sequelae of what we might do to treat them. So it's a huge program for us as far as the importance of it. But I think that, this whole thing started, I first learned of L-Dex in fellowship. And when I started practice like 7 years ago, I had a patient who was in her 30s, diagnosed with breast cancer. She had an axillary node dissection, and a couple years after, her mother said, "We're very, very grateful. What can we do? What can we provide that can help? Because we see her future now, which we didn't see a couple years ago. What can we do? We want to donate something." So they actually funded our L-Dex unit, which was, how the whole thing started. You want me to keep going because it was a very long.
Sure. No, I think that's great on how you started. So can you talk a little bit about where you are today?
Sure.
How does your program work today? And what have you kind of learned?
So to get from there to where we are now has been a lot of struggle. So I want to put that out there. And it has been absolutely vital to engage with ImpediMed and accept the help that you're providing, because unfortunately I had to learn the wrong way. As we got the L-Dex in 2017, I think it was at that point it had leads, and we were kind of just testing patients who were symptomatic with lymphedema and trying to prove that they had lymphedema to trigger their intervention. Then we started to see how easy it was to do and how we really should be using it as a screening tool. But we started to run into some problems with the cost of the leads, and this being a higher volume of patients, and administration got wind that I wasn't actually charging for this. So we then started looking at reimbursement. So that was really when we started forming a real program. So we were very happy when we got the SOZO, because leads were no longer an issue. So that really cut down the costs there, and it made us not have to feel selective about who we tested, because we were kind of arbitrarily selecting criteria to figure out who's the highest risk for lymphedema. Do they have an axillary lymph node dissection, or do they have a lot of lymph nodes removed, or some pre-existing risk factors? So it started to become an issue when we went to reimbursement, and payers weren't covering the SOZO, which was considered experimental, and patients were getting balance billed up to $400 some. And so while we worked very hard to adjust the cost to make it similar to Medicare coverage, we brought it down to like $140. We also started having patients sign that advanced beneficiary notice of non-coverage. Just that period of having those patients get that bill was a big, impediment. Not to use the name again, but I mean, with the concern of having to incur that cost again, the highest risk patients were now becoming the ones who were dropping off and not getting the test. They were declining the test, so we were starting to fail. And it was also becoming very burdensome for the office staff. When you mentioned that there's always turnover with the office staff, it was getting very burdensome for our office staff to kind of search through the EMR. Who is high risk? Who needs to be tested? How many lymph nodes did this patient have retrieved? And there was a lot of paperwork that went into that, with it not feeling worthwhile because it was still getting denied. And they had already, like Chelsey said, there wasn't the bandwidth to go through all the extra steps and the appeals. So it kind of brought us back to, why did we even start this program? We want successful survivorship, and it's not at all hard to convince a patient why we do it. We're thinking of their future. We're anticipating their survival. We're kind of imagining their life after cancer, and their life should be one with a reasonable quality of life, not wearing garments all the time, not with cellulitis, and as quickly as it can be done too. It's not adding much to their visit. It's not, it's not time consuming. It's very straightforward. So then it was really, how do we convince administration, our system, that we should do this and that it's the right thing to do? So that's where these accreditations come into play, because I was able to frame it as a quality improvement measure for our maintenance of accreditation. And now that there is such a focus on survivorship programs, this is certainly something that affects patients long-term and is a very important item that is sometimes overlooked as far as what we do to treat patients and how their life is affected later on. And it was kind of luck that we partnered with a physical therapy group at that time, which could handle the downstream flow of patients who might need to be tested. So we decided to change how we were doing things and tested everyone. So instead of knowing that Medicare was starting to reimburse, we felt that we were being too selective, and we were really narrow focused. So we are testing all newly diagnosed patients now. And then for follow-ups, we're testing any patients that had any type of lymph node surgery. And by testing that larger population, knowing that we will certainly get coverage for the Medicare population, we of course go through that whole process of appeals if there's a denial, but the system has agreed to adjust that charge later on, because the Medicare patients will essentially cover the cost of the unit and provide additional revenue beyond that. So it's I know it's a long story, but it was a big kind of shift from where we started to where we are now. And it certainly takes a lot of negotiating, but I think it is so worth it. And it's good to see that we're now in like a successful, smoothly functioning lymphedema prevention program.
Thank you, Dr. Kohli. Really appreciate your walking through that. And I think you hit during your talk a lot of the things we wanted to ask you about. As you've seen, you said you went from testing only high-risk patients to now testing everybody. You went from balance billing $400 to not balance billing at all, and sending everything to Chelsey and her team for the case assistance program. What has been the impact on patients? What are you hearing from patients with where you are today?
I mean, I'm hearing not just from the people that look at our, how successful our practice is, that, wow, things are really looking good financially, but also that we're detecting subclinical lymphedema in patients who would have never met our criteria for being tested before. Patients who might have had one lymph node removed, but we're detecting that and we're sparing them from potentially getting advanced lymphedema later on. So I think that's the biggest thing, is that there's a big population of patients that you may not expect to get lymphedema, but it is something that can happen no matter what. So that's one thing. And the patients are very appreciative. Once I can convince the patients that previously were balance billed to actually get it, it's a great thing, because we're identifying lymphedema very, very early. We're able to partner with our physical therapist, get them in, reverse it, and have them live comfortably. So I mean, it is a win-win when you really look at it.
Mm-hmm. Thank you. So we're getting a lot of questions. A lot of them have to do with how to implement a case assistance program. So I'm going to go back and forth to the questions and ask both of you about some of these. But Chelsey, just to start at the top of the list, we've got a question about commercial payers. You talked a lot about the importance of the predetermination process. Have you been able to get denials overturned without pre-approval or predetermination?
You can't go through the appeals process unless you have initiated a predetermination. And let me go through the example of a pre-authorization and a predetermination are different. So because this is deemed experimental investigational, if your pre-auth team calls up to request a pre-auth, that insurance company will say no pre-auth is required, because they essentially aren't going to cover it, or say they aren't going to cover it. So we initiate a predetermination that's based off of medical necessity and off of their medical policy. So we find gap exceptions in order to provide coverage for that patient.
Interesting. And how do you handle the predeterminations in your office, Dr. Kohli?
Okay, so the way that things work currently, we rely heavily on the case assistance program. And I will say that there's also, just as a sidebar, there's a really great handbook that was made that has been helpful, because we do have turnover in our office and it's hard to explain why we're doing this and who's doing what. But basically what happens is the first step was actually getting an agreement to have access to our EMR. So that was at the system level, getting that approval. Once we were able to grant ImpediMed's case assistance program view only access to our EMR, then the office staff actually will look through all of the patients for an upcoming period of time to determine who had lymph node surgery. And they'll also look at the new patients coming in who has a new cancer diagnosis and make a list and forward that to the case assistance program. So then the pre-authorization happens. From a clinician standpoint, I document with that blurb, which is extremely helpful to just drop into the note, the reason why, in case there is a denial, that there is clinical documentation to back up why we're doing the study that can be submitted to try and appeal it.
And you're talking about the smart phrase that Chelsey discussed.
Correct. And that's been really helpful, because, we really are just dropping in. Is it a baseline? Is it a follow-up? What is the measurement? Then it basically is, as far as I'm concerned, then it goes to our billing department if it's not approved, and they adjust that charge if needed.
Okay, thank you. Now, how do you know if it's working? So we have a question. If someone's in the program, how do they know it's working for their office?
Well, how do you know what's working? So we provide weekly case status reports of all the cases submitted. We exhaust all levels of appeal if necessary. So we've seen 1,867 cases, and only 8 of those cases have exhausted all level of appeals and not been approved. So that's where we get our 98% approval. I really, we work very closely with the front office and the revenue cycle team. So we will also have the revenue cycle team provide us a monthly report of the denials that they are seeing coming in from the payer, because obviously there's a difference when, if we get the predetermination the same date of service and you drop that charge the same date of service, that authorization number obviously isn't included when they submit that claim. So in order to capture that, we have the revenue cycle team forward us a monthly report, cross-reference our patients, and then can submit a post-claim denial appeal and provide that authorization number, whereas before it may have been missing on it.
And of those 8, anything they have in common with each other?
They did not have any of the documentation included. There were no documentation about the assessment included in those.
Interesting. And Dr. Kohli, what have you been able to do to help show your organization that it's working?
I think the most important thing was showing that it wasn't working when they were balance billing, because we could see with the reports you provide us the volume of patients that were being tested, new and old, and when that ADN was set in place as a policy, how few patients it was a handful of patients that were being tested monthly. That was a big catalyst to say that we can do better. So it's always good to have that real-time feedback to know exactly how many patients are being tested. And it's very, very helpful. So, I mean, I can't reiterate enough how heavily we rely on the case assistance program and how it has streamlined things for our office.
Excellent, thank you. We have a question about how do you not bill the patient if your payer agreement restricts that? Chelsey, are you familiar with payer agreements that restrict the opportunity not to balance bill?
Yeah, so we have, that's when we develop specific workflows. That's why I said every workflow with a site is different. There isn't one that's the same. So we do work with a site in Texas, and their payer contract, we cannot appeal over a first level appeal with an Aetna, for instance. But they didn't have any documentation included, so we worked very closely with them, and we're getting predeterminations with them. So, depending on your payer contract, hopefully we wouldn't even have to, depending on how many levels of appeal, or if there are any, we wouldn't have to do that.
And we're getting we actually have a couple different questions here about point of service. One person talks about she's forced to have a point of service of 19. A couple others have 11 and 22. What's the impact of point of service on getting reimbursed? And is there any certain codes the team should be aware of when it comes to point of service or place of service?
So place of service 11 is different. If you're a physician, place of service 11 is office. If you're physical therapy, that is freestanding. So it's 2 different completely things. So I would need to know where they were or who was asking the question. I get, with Noridian is a MAC. So the place of service 19 and 22, I was notified by an institution in Oregon that they weren't getting any kind of reimbursement of 19 and 22. So I reached out to the medical policy contact at Noridian. 19 and 22 were added to the fee schedule for them. So if you aren't getting a particular reimbursement for a place of service, just let me know, because I can work with the different local MACs and their medical policy committees to see if we can get them added.
Thank you. Great answer. And we have a question from a therapist who's in private practice. So how should she handle reimbursement if she's in private practice?
Her individual payer contracts, work with the provider reps to see if they can add the 93702. I can also provide some assistance. I think I know who that is anyway, so we can connect offline. But I have been working with a few, one in Maine, one in New Hampshire, and getting individual contracts with specific commercial payers and Medicare for inclusion of the 93702 for them specifically.
Okay. Thank you. I'm just looking at some of these other questions that are coming through. We have a question about a waiver for patients to sign about being content to be billed. We have that. So if you're looking for that, reach out to your ImpediMed representative, reach out to us. We can get that to you. We're having some questions about how frequently patients are assessed for lymphedema using L-Dex, since it can develop even years later. Dr. Kohli, what's your current protocol for assessing patients? How long are you doing it after the patient's index surgery?
So it is technically supposed to be every 3 months, but I am doing things a little bit differently. I'm doing a baseline, and I see my patients on a 6-monthly basis because they're seeing like medical oncology. They have numerous visits with other departments, and I don't want to overburden them with a visit. Now, if they have an abnormal measurement, then they will be called back in for to be remeasured after an intervention. So we'll either refer to physical therapy, we'll have them fitted for garments, and we'll have them return in 4 to 6 weeks to see if there's progression or improvement. As far as how long to test them, I mean, I have no problem with continuing to test them forever, because it's not as if lymphedema risk declines at 2 years or 3 years arbitrarily. I think that it's such a quick test to do, and it's so easy, especially if you're thinking of it as like a vital sign and truly treating it as that. It is a vital sign for what we do. The information is just as vital as like a blood pressure for a cardiologist. And it's not time consuming. So I think that I haven't yet to find when I'm going to stop doing it. I think ever.
So thank you for that.
I need to stop. Don't make me stop.
And we're also getting a lot of questions, a couple of questions here about total cost. So you talk about break even versus generating revenue for the practice. What do you kind of look at that as far as what's the incremental cost or resources on implementing this program, not just from the device itself, but from the staffing needs and everybody else who kind of goes into it? What does that look like? How much time and effort does it take from your team to implement this now that it's up and running?
Now that it's up and running, it's, the test takes very little time. I think you need to make sure you have appropriate team members that are willing to do that legwork of just going through and so you have to define who you're testing and have somebody compile a list. I did not need to enlist any new staff just for this. So that's the other thing is it's always a good idea to know what you're going to do with the results and have that in place. So I think that kind of aligned nicely when we partnered with a very large physical therapy group, because if we're going to test all these patients, what do we do with the results? So it was, it was very good timing, because in those early days when we were very selective, it was very hard to find a lymphedema therapist or anywhere to even refer them for appropriate care. So I think those are some important aspects.
Thank you, Dr. Kohli. And, we have still a lot of questions. I don't think we're going to get to all of them, but we will follow up with all of you who've asked a question. So please look out for contact from an ImpediMed representative. So Chelsey, we've talked a lot about the case assistance program, but not all practices want to work with the team. What are the options for practices who want to do pre-authorizations and appeals but don't want to use ImpediMed's program?
So I have provided training for individual sites on how to do a predetermination versus a pre-authorization, and for many different sites, actually. So I walk them through how to initiate it, what particular payers, because there's 4, can initiate it by phone. The others, commercial payers, you have to submit by fax. So then we provide them all the fax numbers in which they would submit the predeterminations. There's a lot of legwork to it. We have the example template letters that they can provide that incorporates the clinical information of the patient with the technology information to show medical necessity. I think, with the sites that don't want to utilize our program, they should just reach out. I can provide them all the template letters, but most importantly, the Medicare Advantage template letter, because that's going to be additional revenue for your practice, your site. It will get covered. Medicare is covering it. So commercial Medicare Advantage has to follow Medicare guidelines. So we've included the fee schedule to Medicare in that template letter. So if anything, reach out and get that Medicare Advantage letter to submit for a pre-service review.
Thank you, Chelsey. And Lisa, would you mind sharing the closing tips? Thank you. So would love to hear from both of you. Chelsey, any final thoughts on some of your top tips for the folks on the phone about what they can do to be successful with billing and reimbursement?
Sure. So definitely implement that EHR documentation, that SMART phrase that has been a critical piece that has provided commercial payers those cases to get overturned upon appeal. That's number 1. Number 2, try that pilot program. Don't balance bill your patient. Get that utilization up. You'll see that you are going to break even, if not generate revenue.
Thank you. And Dr. Kohli, any final thoughts for the team as they think about embarking on both starting a lymphedema prevention program, or some already have it up and running and they want to start billing? What are your thoughts for the group?
I think these 3 tips are right on point, and I think that it's really important to just reiterate if there are those obstacles like I had, reiterate why it's being done and the benefit not only to the patient but to the system. It is revenue generating, but it's the right thing to do, more importantly. And if you are, there's this kind of push to refer to the in-network this, that, or the other thing. So then you're increasing your in-network referrals to physical therapy. But again, at the end of the day, you're doing the right thing for the patient and everybody wins. It's so, and asking for help is really important. If you really want to stay committed to that goal, then I would, I'm happy to answer any questions from anyone if they have them for me, but I've been just trying to figure it out as I go and really leaning on you guys to help us. So really appreciate that, by the way.
Thank you, Dr. Kohli. And we had a nice compliment for you in the Q&A of the audience admiring your commitment and that your patients are lucky to have you. Mm-hmm. It definitely has taken commitment from you. So thanks, everybody. This is going to wrap up today's webinar. Stay tuned. This is our last webinar of the calendar year. Next January, we'll hear from High Point Therapy in Indiana, who's done a great job building a successful lymphedema prevention program, everything from documentation to workflow to testing to billing. So we're going to hear from them. And then in March, it's going to be all about L-Dex. And we're going to discuss the ins and outs of L-Dex and how to use it, how to understand it scientifically and how to use it clinically. So stay tuned. I hope you all have a wonderful holiday season. And thank you, Chelsey and Dr. Kohli, for this great webinar.
Thanks, Joanne.